Good morning. My name is Michael Nurok. I'm from Cedars-Sinai Medical Center, and I'm going to be talking about how to define an FTE in critical care with a focus on relative value units. My only disclosure is I received stock options for Avant-Garde Health as I'm an advisor. So there are two big buckets in trying to define an FTE. The first is clinical and the other is non-clinical. I'm going to focus primarily on clinical here. The most common unit of measure is a relative value unit, and I'll talk a little bit about that in a moment. Other ways that you can measure an FTE are patient contact time and clinical shifts. So first, the history of RVUs. In 1966, Medicare developed the current procedural terminology codes, and that was an effort to standardize how medical interventions were defined. So that would be a clinic visit or an appendectomy, to try to use standardized language around that. In 1988, there was a group at Harvard School of Public Health that did a study, and they created what were called resource-based relative value scales. They took something like 30 individual procedures and tried to get a sense of how much effort went into them and how they should be differentially valued. And I'll share that with you in a moment. In 1991, CMS created the Relative Value Scale Update Committee, or the RUC. And the RUC had representatives of different specialties on them, and they took those relative value scales and said, how much value or how much monetary value should we assign to each of those, to each RVU, and how many RVUs should be assigned to each clinical current procedural terminology code. So something like an appendectomy would have a certain amount of RVUs assigned versus clinic visit would have a different number assigned. In 1992, CMS began reimbursing based on values that were established by the RUC. So here's the output of the original study that developed relative value units. And they had four big categories. The first was the time to perform a procedure or service. So how long it took you to see a patient on average, or how long it took to do an appendectomy or thoracotomy. The second was the intensity of work. So how much mental effort, judgment, skill, physical effort, or stress went into doing a procedure. And obviously something like a clinic visit would be very different to doing cardiac surgery. The amortized cost of specialty training and the overheads, and also included the cost of liability insurance. So RVUs are problematic for a number of reasons. I'll start just by saying they do have a role in medical centers deciding how much total work they have and how many physicians they need to get that total work done. That gives them a sort of ballpark figure of how many FTEs you need. But in terms of measuring individual physician performance, that's not what they were created for, and that's not what they should be used for. Nevertheless, most centers do use RVUs to measure performance, or at least they track them. Systems that look at RVUs to measure performance versus those that use other mechanisms, those that do use RVUs tend to incentivize more and highly reimbursed procedures and cares. So it incentivizes volume, not necessarily value or better outcomes at lower costs. RVUs tend to overvalue procedures and undervalue public health. And I'm told that if you sit in one of these RUC committee meetings where you have people fighting out how many RVUs should be assigned to procedures, often the surgical specialties that are given sort of are often overweighted compared to things like public health that we should, as a community, value. They're not well aligned with patient and community interests. So if you as a physician spend more time, have better patient outcomes, if your patients have better experiences, RVUs don't measure that. They don't account for that. They also don't measure research, teaching, or administrative effort. And they don't account for the professional ideals like citizenship or collegiality that are clearly important. So how then do you define work in acute care specialties? So I thought it would be useful to think about different specialties like emergency medicine, anesthesia, critical care, and try to see how they think about these issues. The World Health Organization defines acute care specialties as being time sensitive and treating patients that need frequent rapid intervention. They usually have 24/7 coverage. They often have overnight responsibilities. They're emotionally taxing, and care is often episodic, so they share a lot in common. Based on survey data, here's an intensivist survey that was published in 2016 for full-time intensivists, with the caveat that most of these were in urban settings and working in not-for-profit hospitals. On average, intensivists were working about 169 days a year with 24.1 weeks per year. The interquartile range you can see there was reasonably wide. They worked 24 weekend days, and that ranged from between 18 and 30 days. And many of them had nights in-house, which I think is consistent with most anesthesia departments' approach to critical care. In terms of society recommendations, the American College of Emergency Physicians says that shifts should be no longer than 12 hours, that there should be regular periods of time off, and that in deciding how much effort goes into an FTE, that the ED volume, the patient acuity, and other responsibilities, including the physician's age, should be brought into consideration. FCCM also suggests that staffing ratios be no more than 1 intensivist for 14 patients. Clearly, if you've got a bunch of strong fellows supporting you and APPs, then that makes work less taxing than if you're trying to do this all yourself. Other things to think about are that intensivists from anesthesia, medicine, surgery, emergency medicine often split their time between doing ICU and something else. So that needs to be considered in dividing up an FTE. You need to think about what the unit structure looks like in terms of how much effort. So if you're working in a cardiothoracic or ECMO unit, that's a lot more taxing than working in a community hospital, and deciding what an FTE in those different settings looks like should be a little bit different. I feel strongly that you do need to reward citizenship, professional and scholarly values. Those are things that need to be promoted and encouraged, not just revenue generation. Nights and weekends should also be valued more than days. And I think we need to guard against incentivizing people to the point where they are going to burn out by trying to make extra money. So with that, I'll stop and hand over to Mark Nunnally, who's going to think a little bit about how you think about an FTE, how much work should go into different units with different acuity. So the example of the ECMO unit compared to a community hospital ICU. Thank you.
Hello, my name is Mark Nunnally, and I will be presenting on the question, should the nature of work be considered an effort? In other words, if we have a specialty ICU like an ECMO ICU, should work there count more than in a community ICU? By nature of disclosures, I have no financial relationships to disclose, and I won't have any discussion of off-label or investigational use. But to the question at hand, my short answer is no, and I hope to spell that out through a variety of different insights. I will spend some time talking about specialty pay and the established economies there, work pay and the problems with paying for what one does. We'll talk about cross-staffing, the role of citizenship, extra pay and how it should be handled. I'll touch on perverse incentives, which are a fundamental problem when dealing with this issue. And then we'll talk about the impermanence of ICU work and the constantly changing nature of what it is we do. So delving into this, the first place I'll start is with the caveat that I'm not trying to say that practices aren't different. They are different. But what I'm saying is that markets are established and they're actually relevant and fairly even, at least they've been socialized as even between different practices. And my argument is actually for alignment with proper markets. There are a couple of other considerations that always have to be addressed when looking at ICU work. One is when hours. These are the weekends, the holidays, the evenings, and the nights, which may need to be valued differently than daytime work. But that's a nature of what the clinicians are doing to run the ICU service, less than the actual structure of the ICU itself from a specialty standpoint. And fitting into that, obviously, is the role for reimbursement of home call. So touching on specialty pay, the first place I'd start is with my CMO presents me with as a question all the time. What is the problem we are trying to solve here? It's such a fundamental question, but it's important because it informs the answers that we want. So we need to think about what the problems are with ICU reimbursement, what our goals are, and how best to achieve them. If I'm going to staff an ICU, I have my masonry of the ICU concerns that I want to address. So those may be excellent clinical care, harmonious relationships between services, the stewardship of resources, reduction in my healthcare associated conditions, my staff satisfaction. Overlapping, but with a slightly different bent, is my academic or ivory tower model. Now here I'm thinking about recruitment, retention, growing careers, realignment of services around educational or academic pursuits, supporting a major program perhaps, that ECMO unit comes to mind. Favorable reportable metrics, which may be hacks, but may be other things, and the generation of academic coins, so grants, publication, educational output, things that will be important to sustain and grow the people that I'm hiring to staff ICUs. Well, from the masonry standpoint, you want to get the best people at market value. And that means you're typically going to pay by specialty because, as I mentioned, specialty pay is well established and it's well conditioned. Now, obviously, specialty pay changes over time, but everybody generally understands the framework. And when they graduate from their primary specialty, they understand roughly what their reimbursement will be in relation to their peers. That pay differential is acceptable. It is well socialized. There's another key component here, which is that different specialties are paid differently because they may have alternative streams of revenue. So some of my ICU staff might also be able to staff ORs, either as proceduralists or as anesthesia providers. They may be able to work in other settings, including clinics, including doing outreach. And those are different ways to get income. And that's built into specialty pay. Specialty pay models create a home where people feel comfortable, both in dealing with like peers and also dealing with colleagues from other specialties. On the academic side, you can take this to another step, and that is that the home career, the primary specialty, is also the home specialty in terms of academic growth and promotion in the vast majority of cases. Services in the ICU are by definition interdisciplinary, but the way we have arranged subspecialty homes, people are very comfortable with their relationships. And when I say interdisciplinary, of course, it's the relationship between the specialties that is as important as the variety of specialties. The academic model, the specialty model makes this possible. Everyone can contribute and everyone has a voice. And at the end of the day, the academic home of the individual is their specialty. Of course, they don't address work type. And here's the peril of trying to figure out how to incentivize or pay for, reimburse specialty units based on the work type. It just gets messy. If you have an overlay of specialty pay, which is established, it gives everyone a thought process around negotiations that is on one vector. When you add work type, suddenly you add another vector, and it makes the likelihood of both parties after a negotiation feeling like they have gotten something and that they have a positive outcome much, much lower. It's just a messy calculus to do. You never feel like you're going to get it right, and importantly, you're never going to satisfy key stakeholders. An ICU service also shouldn't eat what it kills, and I'll talk about that a little bit more later, but what you don't want to set up here is either competition against yourself or perverse incentives. Again, more in a little bit. And the ICU is a project, so you have to think about how you're going to staff it as a project. You staff it with a team. Getting everyone to play their role and to play their role harmoniously is important. Specialty pay allows for that. Type-specific pay tends to set up gradients and incentives that actually antagonize that process. We'll spend a little bit of time on work pay because I think this is a fundamental issue when you talk about reimbursing for work in ICUs. Here's my list of what I think critical care is really about from the standpoint of the intensivist. And you'll see everything I have listed here is cognitive work. What's missing is technical work, specialty work. What's also on here, I should note, is social work, which is just as important. Intensivists need to broker deals between different specialists. They need to coordinate care in a very complex way. They need to manage and allocate scarce resources. They need to be good at prognostication and the communication of what that prognostication means for the care plan. At times they need to placate, and they definitely need to document the processes of care in a meaningful way. All cognitive specialties, all established in a flawed but existing framework that we can talk about. When I'm hiring, the emotional intelligence of a care provider in the intensive care unit setting is really important to me, because the technical aspects like managing ECMO or doing specific procedures, dealing with a specific subtype of patients is something that can be acquired and learned. And in fact, that learning continues over time. Also more on that later. So my question would be, how different are these cognitive activities between units? I will argue that they're actually not that different. Acuity may vary between units, but the cognitive work still exists. And interestingly, the variety of acuity can be a satisfier and a negative satisfier. In other words, some people will just gravitate towards high acuity units. Some people will prefer to work in low acuity units. It's this work with the cognitive details and the social details that really is important. And that work is what attracts the talent. Cross-staffing is so fundamental here. We're going to have people from different specialties that have to intersect. So how do we get them all to get along? And no surprise, I'm going to make the argument that using established markets and using an established specialty pay scale is the easiest route to make that happen because it's socialized and people accept it. Furthermore, think about specialty units as being incidental to the work done. In some cases, you have individuals that would staff an ICU, like cardiothoracic surgeons, but they're far too valuable in other settings, and so you need to bring other specialists in. In other instances, like neurocritical care, you may have the specialty grow into a natural home caring for sick neurologic and neurosurgical patients, but it doesn't mean that other specialties can't work in that environment as well. Diverse staffing has benefits. I advocate for a diverse staffing model. You get the flexibility and the perspective, and people can bring their own skill sets, which may be technical, but also maybe things like outreach and triage to help the service overall. Getting people to work together well is important, and specialty pay is the easiest way to make that happen. That brings us to the topic of citizenship. You want your providers in the ICU to have a vocation. They want to be there dedicated to taking care of the work. And what that means is you don't want to make this just a transactional issue. Fee for service very much is transactional. We'd rather that our providers and our professionals see the ICU patient as their problem, their ownership, and they dedicate themselves to taking care of it. You don't want to sell critical care by the pound. And you definitely don't want to compete against yourself. And in fact, when you set up fee for service incentives, you can end up competing pretty perversely. As I mentioned before, if we talk about a fee for a service or an ICU type, and we overlay that on the specialty model, we now start moving things in two different vectors, and it's very hard for people to feel like they've achieved common ground when there's that much complexity. We also want to reject elite membership. It's not that one set group of providers is better than another. They simply are different, and we're using established models to show that. You should reward stepping up. That includes potentially paying moonlighting for additional service time, but the best way to handle moonlighting is on an even scale that's transparent to everyone across the institution. It's not getting it right to the absolute last cents, because the real goal here is a sense of commitment to the common cause of your ICU. Now we'll move to perverse incentives, because I think this is where the rubber hits the road when you start thinking about reimbursement models. At the end of the day, an ICU service shouldn't eat what it kills. I said I would talk about that. Here are some examples. The first is length of stay in the ICU works very well for service billing. If I can drop additional critical care charges, that's good for the bottom line of the service. But from the hospital standpoint, that reduces their efficiencies, their capacity, and their throughput, and they actually take a disproportionate hit. And so thinking like a healthcare institution, monetizing things like fee for service leads to perverse incentives where you have problems with throughput through length of stay, or problems with perhaps questionably necessary procedures or unnecessary procedures, again, working against the hospital's best interest. You do incentivize people with your reimbursement structure, and you can set up very perverse examples where, for example, different services might compete over codes, racing there to be first so they can bill for that time, or fighting over specific patients. You get into payer issues, which should not be driving medical decisions. All these are perverse. We've seen a lot about surprise billing of late, and that was driven in large part because of perverse incentives. If patients came home from a procedure where they had a minor complication and received two bills, one of which was much larger than the bill for the procedure they had, they're not very happy, and that's not good for the healthcare institution. Clinical decisions should be clinically indicated. Finally, I'll touch on impermanence, because critical care is changing. It's one of the most dynamic medical specialties, and I like to say that we change our patient types every 5 years. Sometimes it's a shorter time frame, sometimes it's a longer, but any of us that have been in the profession more than a few years have seen this happen. We just have different patients and different priorities. So the difference in the work done between different ICUs would be expected to change over time as well. You think about some procedures that are largely, not completely, but largely obsolete, and once were very common, like open aortic aneurysm repairs or low-risk CABGs. And then the reduced risk of other procedures. Prostatectomies now is practically an outpatient procedure. We hardly ever see these patients in the ICU. Yet once upon a time, we may have seen them much more often. What that means is The difference between ICUs may be a difference that only lasts 3, 5, maybe 7 years. My bottom line in making these arguments is that specialty pay still makes the most sense. The work a unit does is a minor consideration at most. And the reason for that is, first and foremost, critical care is a service. It's not a specialty. And that service is provided by teams. And these teams are multidisciplinary, coming from different backgrounds. Their good working relationships within and between each other are what define quality ICU care. Those teams work best when they're aligned with established and socialized markets. And importantly, the incentives in the reimbursement scheme are critical to hospital operations. They should not work against them. Competing against yourself, setting up perverse incentives, these are the things to be avoided at all costs. And of course, conditions are always changing. So the rules of engagement on anything but a service-based reimbursement platform would be expected to change quickly as well. I will not have the opportunity to answer your questions live after this session because I am not away or not present right now, but I will leave my email here. If you do have any questions, please feel free to send them to me. Thank you very much.
Hello, everyone. My name is Megan Lanefall. I'm based at the University of Pennsylvania, and it's my pleasure to be with you virtually to talk about the future of reimbursement for surgical critical care services, part of a panel for the SOCCA annual meeting. So this is my disclosure slide. I have no financial relationships to disclose, and I won't talk about any off-label or investigational use. The objectives for the short time I have with you is to describe the current reimbursement landscape for surgical critical care in the US, and also to talk about some financial pressures in health systems that might influence reimbursement in the future. I do have to give you some caveats, though. The first and probably most important one is that this is entirely focused on the United States, which is a very interesting relationship to billing and reimbursement and care for patients in general. The rules of the road in the US are largely set by Medicare, by the Center for Medicare and Medicaid Services, which is one of the largest payers for healthcare in the US. Secondly, it's important to note that reimbursement is a bit of a moving target, and that Medicare and other private payers change the rules for reimbursement on a regular basis. So really your key go-to for your organization is going to be the billing folks that work at your own organization. And they will be the ones that give you guidance, and they should be the folks that you consult with before you change your reimbursement or billing practices. Next, reimbursement for critical care services is not the same as remuneration to the billing provider. So here what I mean is that reimbursement is really something that accrues to the organization, but you as a provider, and I'm thinking here mostly of billing providers, are not necessarily going to see that as in terms of compensation. Next, local regulations may influence reimbursement and documentation, especially as we think about billing or reimbursement from the perspective of non-physician providers. The ability of non-physician providers, like physician assistants or nurse practitioners, to seek critical care reimbursement is really dependent on the privileges allowed to them by states. And then finally, the rules may be different for neonatal critical care, which has some different billing procedures than adult critical care. So I've been asked to use my crystal ball a little bit here and to talk about the future of reimbursement in critical care. I don't know what the future holds, none of us do, but we can use what we know right now to give us some insights about the future. So first, I want to talk about the current state of critical care billing. In the US, critical care right now is largely fee for service. What that means is that you are remunerated or reimbursed, the institution is reimbursed based on the actual care that's delivered. And critical care is a little bit unusual in that that reimbursement is time-based. So you have to have at least 30 minutes of qualified critical care time delivered to a patient who requires critical care to be able to designate that CPT code of 99291. CPT here stands for current procedural technology, and it's a way to talk about reimbursement for critical care. Beyond, so that first 30 to 74 minutes is under 99291. Beyond 74 minutes, you can bill CPT code 99292 for every additional 30 minutes of critical care time. But the key takeaway here is that the billing or the reimbursement is based on the time that you spend and the time that you declare that you spend taking care of any given critically ill patient or a patient who's at high risk of deterioration. There are certain procedures that we do in the course of critical care that are actually meant to be bundled in with that time. So pulse oximetry, EKG interpretation, ventilator management on their own could be billed separately, but when you do them in the context of critical care, they cannot be billed separately. They're meant to be bundled into that 99291 code. There are other procedures, however, that are separately billable when you do critical care. Some of those procedures are performing CPR, but actively being in CPR or supervising CPR, central line placement or endotracheal intubation. Tube thoracostomy would go in here too. So if you do these procedures, you can separately code them, separately bill them. They should not be counted in critical care time. So any time that you spend doing these procedures should not go in that critical care time. So it's sort of a complicated system, but those of us that are in practice kind of understand it, we work with it. There are a couple of good things about the way that we do things now. The fee-for-service payment models in general favor the provider, favor the institution. So one of the reasons that it's useful to have fee-for-service payment models is that it maintains the independence of separate provider pools. So for instance, we're anesthesiologists. Many of the people in SOCCA are anesthesiologists. We can develop our billing and our reimbursement independent of surgery. And as I'll talk about a little bit later, there are movements in surgery to bundle all the payments together. That presents some challenges for figuring out how to compensate different providers who fit into that critical care model or fit into that overall global patient care model. But if you have a fee-for-service model, the anesthesia group can decide this is how much we want to pay our providers, this is how we want to structure our service, and that can be done largely independently of what's happening with surgery or nursing or other groups of folks. For those of you that are in private practice, non-academic practice, there's a bit of an opportunity to eat what you kill, meaning you can see some increased compensation to yourself related to what you bill. Certainly there's an opportunity for that to be abused that is important to call out. Finally, or additionally, this helps support service lines. So as we bill for critical care, we're able to stand up critical care lines. And so it's a little easier to argue to hospital administration that we need specific service lines. And then finally, it forces robust documentation. It's the least favorite part of my job, but certainly as I'm documenting, I'm thinking about reimbursement, and it makes me be much more precise about what I'm doing and why I'm doing what I'm doing. There are some bad things about how we do reimbursement now. Fee-for-service is often thought to be bad for payers and patients. It promotes overuse of procedures because you bill for everything that you do, so there's an incentive to do more. The fee-for-service model compensates hospitals and providers for complications. So if something goes wrong or goes south with a surgery, guess what? The hospital gets paid more because they get to render services for all those complications, and that's a bit of a perverse incentive. The system is a bit prone to fraud, abuse, and error, and we've seen increases in the audits on procedures and audits on billing in critical care. And then it increases documentation burden for busy providers who have a lot of other things to do. So where are we going? This is where the crystal ball comes in. It's a little bit unclear, but we know that there is an increasing focus on value and that bundled payments are on the rise. And the goal of the bundled payments and the focus on value is to reward healthcare providers for giving better care and not just more care. Right now, the fee-for-service model favors just delivering more care. One interesting development in this space relevant to surgical critical care is the development of quote unquote global rules or global surgery, where some surgical procedures have the post-operative critical care actually bundled into one payment. There are conditions where surgical critical care can be billed separately from those global surgical payments, as long as the critical care is unrelated to the surgery performed. And of course, you could see that there's a bit of fuzziness here, a bit of discretion, which means that it makes the billing and makes the reimbursement a bit more difficult. I'd encourage you all to look at the global surgery booklet from Medicare from CMS that provides a little bit more insight into what global surgery means, what that bundling of payments together looks like, and the implications for surgical critical care. Thankfully, as anesthesiologists, we have a little bit easier of a time saying that what we're doing with surgical critical care is above and beyond the initial surgical procedure. But some of our surgical colleagues, when they are both surgeons and critical care physicians, have to do a lot of work to demonstrate that the critical care that they're providing should not be bundled into that overall surgery bundled payment. So where else are we going? We're seeing a growing integration of hospital and provider payment. So instead of, the intensivist billing and the hospital billing and the consultants billing, you're seeing one payment altogether, which means that the hospital has to figure out how to pay for physicians, non-physician providers, nurses, pharmacists, all of these other people and services, allied health professional supplies. They all have to pull it out of one bucket. And you can imagine that within a given healthcare organization, the decisions about how to allocate those funds could be pretty fraught. So I think there are a few questions that we need to ask moving forward. The first is, as we think about bundled payment, we think about value. Is there a role for critical care consultation to prevent ICU admission? So if we as intensivists are able to help our colleagues prevent people from getting to the very expensive ICU, is there a way for those savings to accrue back to intensivist or to critical care service lines? Secondly, will financial pressures force changes to physician to patient ratios? So as hospitals take on more of the risk, the financial risk of care, is that going to force changes to the way that we staff and changes to the way that we allocate providers to patients? Third, will bundled payments decrease documentation burden? So if I don't have to bill and justify all of the tiny little things that I do because the hospital's only getting one payment anyway, does it become easier for me to do my job and to document and to say, Mr. Smith is sick, I did a lot of stuff, end note. And then finally, how will bundled payments and a movement away from RVUs or relative value units impact salaries for physicians? So if I'm not able to say I spent X amount of time on a given patient, how is that going to affect my salary or the salary of other folks that are working in critical care? So billing is complicated, as I mentioned. To learn more, I'd encourage you to look at resources from the American College of Emergency Physicians, which has some great guidance on this. SCCM, Billing Basics, also has some information, but most importantly, it's going to be your hospital's billing team because they're going to help you through all the nuts and bolts. And as all of the rules change over time, they'll help you stay responsive. So thanks so much for your time and attention. And I look forward to the live Q&A.
So Megan, thank you, and Mark, who is in Africa, I believe, but I'm not sure about that. Thank you for your presentation. So just I will touch briefly on a comment that Mark made, and then I'll put a question to Megan before we open it up to the audience. I think it's really critical to recognize that there are many people who can look after the patients we look after. They may not look after them in the most evidence-based way, but if I think of our cardiothoracic surgery colleagues, they do a very good job of getting patients through. I may disagree with some of the principles and approaches. So the focus really does need to be on what we add beyond that while they're in the operating room and they're doing other things that they should be doing, and how we advance our mission and provide an evidence-based approach to critical care. I wanted to highlight that, and then I'll move on to the question for Megan. So we don't flay patients open and make them critically ill. We have surgeons who do that for us, but that really limits the amount of volume that we can provide. If you think about it in a sort of factory model, we're rate limited there. That's a bottleneck for us. So how should we think about that and thinking about how work is constituted and how it's reimbursed?
So it's a great question, and I appreciate the opportunity to be here with you and to talk through some of these issues. From my perspective, I think that we have to try to not limit ourselves and to not be subject to those bottlenecks. And certainly I trained as a surgical intensivist. I trained in surgical ICUs, and that's where my home base is and where I'm most at home. But as much as we can expand our territory and care for critically ill patients throughout the health system or throughout the hospital, I think that will be to our advantage. And as I'm not anymore, but I was the medical director of our surgical ICU, And we were faced with dealing with overflow from a medical intensive care unit because they were full and they were capped. And, you know, there were still critically ill patients with medical disease that came in, and we said, bring it, we'll take it. We will work with you. We will take care of them. Where we need some help, we'll bring in that help. But if we can expand our services beyond the world of surgery, I think it's only to our benefit, and we'll help a little bit with that bottleneck.
Thank you. We have a question. I'll just read them as they come from Jack Gucci. Do you predict changes in tele-ICU reimbursement?
Probably. I mean, Jack probably knows more about this than I do. I'm curious what you would say, Michael, but yeah, I mean, I think everything is subject to change right now. And I think that movement toward bundled payment, potentially toward capitated payments, I mean, all of the payers are looking for ways to constrain costs and to shift the responsibility and to shift the risk more onto the clinicians. So I think I could probably say confidently there will be changes, but I'm not sure if we know exactly what those changes are going to look like.
Right, and I think at a national healthcare level, what the pandemic showed was that care can't be bounded by state boundaries. And so that's a problem, and that there may be more efficient models for doing that, tele-ICU being one of them. Interestingly enough, the initial efforts to create telehealth, dating back to the 60s and 70s, were to get into underserved populations. So it was sort of almost an equity push, and I would hope that CMS, which usually leads these efforts, will kind of use that tool to address both equity and access. And I would think that reimbursement will be an important around that.
One of the things I think is not well addressed by our current billing structure is the idea that we sort of juxtapose in-person versus telecritical care or telemedicine care, that it's one or the other. And clearly you can do them together. And so is there a model where you can have maybe cognitive support through a telemedicine model and then actual on the ground care by people who are in the ICU? And is there a way to kind of bill for both, because you've got teams that are working across those boundaries? But I don't know that we have a good answer for that right now.
Rebecca Aslickson asked, do others have experiences working in critical care environments where you're mixing RVUs and salary-based physician providers from different specialties? Some are RVU-based in payment, some are salaried. If you can reflect on that to the group.
I have an answer, but Michael, how about you?
Yeah, well, Cedars-Sinai is what we call a pluralistic environment, meaning that the hospital works to embrace both private practice on non-employed physicians and hospital-employed physicians, with a kind of model that blends a little bit of both of those. It works. It does concern me, though, that the motivations in private practice tend to be very reimbursement focused, not always. And sometimes people are working at cross purposes. So total costs of care, my impression is, are quite high when you have a little bit of a free-for-all about who can do what, and there are different motivations for providing those services. But curious to see what you think. And Rebecca, please chime in if you've got thoughts too.
Yeah, I would say we do have a mixed model. So our surgeons, for instance, are RVU based, and our anesthesia group is salary based. I haven't seen a lot of differences in the practice patterns. What I've seen more is a drag on the surgeons to also provide care in other places. And so they end up straddling, and they're like, oh, I think I can do an afternoon clinic and do rounds in the ICU in the morning. And so they end up just being stretched more, which is a challenge for the whole team.
Yeah, no, I would say the same thing. There are challenges like the patient rolls in and who's doing it, a little bit of competition within group and such. And it's different because there's different historical models for different specialties. And I agree with you, it's a changing system. It is a changing system, and it will continue to change. And so we need to just, I think, be very cognizant about it and talking about it. And for some of my colleagues with RVU-based specialties, I have talked with some, like when we talk about standing up a 24/7 service or an overnight service, that this will be challenging. This will be harder for your service than ours. We will need to talk about this with the hospital. And so I think just everybody's in there for the right, assuming the best interests, best intentions, everybody's in there for the right reasons. And then figuring out how we're going to make this move going forward so that everyone can still thrive. But it's challenging. I'm not going to why it's challenging, especially when you're standing up new services.
Reflections from other people in the audience?
I would say I guess it's nice to hear that everyone is struggling with the same issues. And it is true. I mean, I do think the most annoying part of my day is the documentation portion. And there's a little bit of, sort of gratification when you click on a billing button. So I do think that we're sort of in some ways working against the patient. And, I'm salaried, so it's not even that I'm in any way getting compensated more for the work that I do if I bill more, but there is this like built-in thing where you think that that's like in one weird way your goal. So I'd love to see all this change, but when we have RVU-based specialties, meaning surgery and emergency medicine, working in the ICU, they work by the same rules as the anesthesiology providers. So they do not do surgery that day. They do not go to clinic that day. So I think that in some way works slightly against them in that maybe their passion is more surgery or maybe it's not. But they work in a financial model where they do get compensated for the quote unquote work that they do, maybe, eat what you kill RVU based thing. And we don't allow them to do that. So it evens out some of this thing of, everyone's doing the same exact job, but they're in some ways probably compensated slightly less. And I do think that the hospital backing would be good for that. I would like to know what the future holds, and everyone's talking about funds flow and things like that it's gonna happen at the end of this year for us, but no one really knows what that is actually going to be.
Yeah, and curious that you say that, Joe, just because everyone's employed at UCLA, so here's a model where they should be able to control behavior, but you still around the margins, it's difficult. The other reflection
Go ahead.
on this is just that we've been talking about value now for 15 years, and the penetration of value into the market is still very, very small. It's still predominantly fee for service, and I despite all the levers that have been pulled to try to get there. Sorry, Megan, go ahead.
I agree with you. I think the penetration's been slow. I think it's speeding up a bit, and health systems are also trying to get out in front of it. And so sometimes we're seeing it, even though the pressure may not be coming as quickly from the government, from CMS. But one of the questions that comes up for me is, what do we do about all of this? Like, none of us can predict the future. All we know is that there's uncertainty and struggle and strife and conflict and hair pulling. A couple of things occur to me. One is the importance of anesthesia critical care providers in hospital leadership and health system leadership. And there was a recent sort of slate of articles in ANA about that I think are really, really great. And then the second would be the importance of us being involved at a national level, at a policymaking level, which is really hard. There are some of us there that are either in Congress or, Lee Fleischer's he's the chief medical officer of Medicare. The more we have people who know what we do in those spaces, the more the payment models will at least speak to the realities of practice.
Okay, we've got time for another couple of questions. Let me bundle these together just in the interest of time. So David Liu asked, how do different practices bill APP attending ICU time, separate versus one daily note? How does CMS view this? There's some new regulation about that. We can maybe touch on that. And the second question is, one of the difficult aspects of compensation is post-call days, after days in the ICU. How can this be appropriately valued?
Yeah, I wish I understood how we do APP time. We don't bill it, actually. I think we leave money on the table. Our APPs are employed by the hospital. and they do procedures and we don't bill for the procedures. Like there's a lot of stuff that just for expedience sake that we do with our APPs, and it does help the service run, but we don't co-bill. You can do that in certain ways that it is allowable. And Michael, I'm curious how you do it. And I'm sure there might be others who do that too. The rules are certainly shifting. It is possible to do it, but we don't.
So we do, our APPs do bill. I think the key piece of it is that the time that the APPs spend looking after a patient cannot overlap with the time that an intensivist spends. It's all a little bit arbitrary and fuzzy because these time-based billing codes, no one's really tracking the time. So we just encourage people to be honest. And I think we struggle on both ends, both with our APPs and sometimes with faculty too. So on the one end, you get people who bill 30 minutes only, and they've got a service of 14 patients and they're running around like dogs. And on the other end, meaning that their time is being spent somewhere, so they're not properly accounting for it. And other times, people are sort of billing for the full 12 hours they're there, and that also seems hard to justify. So I think just trying to be honest is key.
One of the other difficulties with the documentation, especially from our APPs, is that they are so busy that even if they wanted to bill, they would have to sit down and document in order to be able to bill. And they don't have the time to do that because they're so busy. So that's one of the challenges too.
And I see Mike Wall just put in that that at University of Minnesota, the APPs bill and collected 85% of a doctor. So that's payer dependent, as I understand it. Some payers will pay at 100%. Many will pay at 85%. What we do here is that gets figured out on the back end. But
and actually, I just saw Jack pop up. Jack knows a lot.
We just discussed this with our billing experts, and the issue is whether they're in your department or not. So if they work for the hospital, then they have more time than you, or depending on what time the billing starts, the bill will your billing will get lumped in with theirs in the submission, and then that whole thing will be submitted and will potentially go to the hospital versus you. So optimally, if you're going to do what Michael Wall was talking about, the APPs would be within your department. So then it would, yes, be a win-win. Or if the whole group works for the hospital and it doesn't matter who's getting the money, then that's also a win-win. But for us, our billing supports our salaries. And so if the APPs take that, then we're out of luck. So the hospital has asked multiple times to do it. And we said, fine, you're just going to have to make up the difference in what we lose. And they haven't agreed to do that. So we're stuck with APPs not billing.
The other way to deal with that is that on the back end, you can decide whether you're going to lump the time with physicians or lump the time with APPs, and you can do that based on the payer. So if your payer is paying you 100% based on for your APPs, it doesn't really matter. If they're knocking you down to 85%, it makes sense to charge the physician and add on the APP time to the physician time.
It also depends on the balance of time, and this I think is also state dependent too. But there are some places where whoever has more than 50% of the time, it's their categorization that matters. So you can't always just decide. You kind of have to figure out how the time was spent.
All right, the question of post-call days. I'll take a quick stab at that. We've gone over to a point system, and much like Mark Nunnally was talking about, where nights are valued more highly than days, weekend days are valued more highly than weekdays. And that really addresses post-call because everyone works the same number of points. If you work a bunch of nights, you're going to have a bunch more days off. We can still consider those days non-clinical days, meaning that that's when you're supposed to be getting your academic work done, and you're not supposed to be on vacation. You're supposed to be in Los Angeles, available to the hospital if necessary. We don't police that super tightly, but in annual reviews, we do look at how productive people have been.
Isn't every day in Los Angeles a vacation?
If it drops below 70 degrees, we get a little upset. But I don't know, Joe, what do you think?
No, I long for snow and rain. Actually, my kids love it when we go anywhere and it's cloudy and rainy. We also value nights and weekends more, and a weekend day more than a weekday. And that system has actually, I think, worked out pretty well. And there are people who like working, you know, weekends or like working nights. I don't know if that's because there's less, you know, political shenanigans, or it's because it's compensated better.
Yeah, we're a little bit more old school. So, you know, we do home call. We were one of the places that did the randomized control trial of nighttime versus not, and there was no difference. And so we're like, okay, great, home call for most of our surgical critical care services. And then for cardiac, we have a shift system. So we're kind of old. It's not that nights valued more than days. And honestly, when we talk about call in our department, it gets a little hairy. So I wouldn't say we're perfect by any means, but we haven't figured out how to value nights and weekends more than days.
Yeah, no, I have heard rumblings from other places in the department that they think, you know, that the ICU team is sort of overpaid or whatever because of those things. And you know, it's funny that you just brought up the debate that maybe was in a SOCCA debate 12 years ago was like 24/7 or not. Finding the value in a 24/7 service is difficult, but once every 4 or 5 nights, there is a critical moment that the 24/7 in-house, either, you know, attending or, you know, experienced fellow makes a significant difference.
I also think it's a truism that once 24/7, there's kind of no turning back. We're the only in-house 24/7 service at Cedars, and we are now the, you know, several times a year we'll get calls from other units to come and help from an attending who's at home and trying to get to the hospital.
Oh, yeah,
I can see it being difficult to unring that bell.
Yeah, definitely. And we've been actually trying to keep track of those little moments where we get called to wherever to do something, who knows what. And of course, we're not tracking that in any way what we should be, because those things happen, you know, once or twice a week as well.
Well, thanks for a great discussion. I think we're at time, so we'll turn back over to the rest of the program.
Thanks, everybody.